Hi, my name is Amr Mohammed. I am an anesthesia consultant in Egypt. Currently, I am working as an anesthesia registrar in Temple Street Children's University Hospital, Dublin, in Ireland. It is my pleasure to be with you today. First of all, I would like to thank Dr. Swayfi for inviting me to be part of the team of COVID-19 conference. I would like to share with you knowledge and experience regarding children with COVID-19. More than 154 published studies of COVID-19 children. Many studies have heterogeneous data. Some patients had been overlapped either in the same center or between different centers within the same country. Evidence was non-peer review in some studies. So it is very important during this difficult time of COVID-19 pandemic to carefully select which paper you're going to read and use as a guide for your practice. As you can see here in this table, I'm going to dive with you through 8 published studies. First one came from China. 2,143 kids were involved. It was published in Pediatrics journal. The second one came from CDC from the States, and it has 2,572 kids were involved. The third one, it was published in New England Journal of Medicine. It came from Iceland. 1,412 kids were involved. And the fourth one here, it was published in JAMA. It came from Italy. 270 patients were involved. So it is different published papers in different scientific journals came from different countries with a relatively good number of kids were involved. As you can see here in this table, the first one came from Italy. 5 kids were involved, and it was published in the PGA. And the second one came from China. 95 kids were involved. It was published in Lancet. And the third one was here in this table was in New England Journal of Medicine again, and it came from Italy. 100 kids. Here is the last published paper I used as a reference for my presentation. It came from US and Canada. 48 kids were involved, and it was published in the JAMA Pediatrics journal. So over the next slides, I'm going to give you an executive summary of the published studies I included in those tables. Epidemiology and transmission. Thanks to God, children are significantly less affected with SARS-CoV-2 infection than adults. Most of the diagnosed cases are in late adolescence. In China, they found around 32 of children that were in the age of 6 to 10 years. And in Italy, they found around 21% of the positive kids. And as you know, Korea, Iceland have undertaken mass community screening. In some cities of Italy as well, they screened around 70% of the population, and they have demonstrated significantly lower childhood. Most kids appear to be asymptomatic, and critical illness is around 1%. In Chinese and USA CDC data, infants more likely to be admitted to the hospital, although the rate of PICU admission is the same, and most of those admitted kids and infants to the hospital, they have other comorbidities, mainly respiratory. Thanks to God, deaths remain extremely low. High-risk group of kids as kids who had liver transplant. There are many reports came from liver transplant units in Italy, kids who had inflammatory bowel disease and treated with immunosuppression, and also kids who had been treated for malignancy. The role of children in the disease transmission is not clear. SARS-CoV-2 viral debris had been detected in the stool of the infected infants even several weeks after symptoms had been resolved. It is just the viral debris, not the active virus, but still it raises the possibility of the fecal-oral transmission. And unfortunately, this virus has a very long shedding period between 17 to 24 days. That's why many of the PICU patients will remain positive even after 4 weeks of the start of symptoms. Neonates are infected as well. There are 50 case reports of infected neonates, one of them at the age of 36 hours. In general, mothers and neonates appear to be in general good condition, although the swabs taken from the cord blood, from the placenta and amniotic fluids remain negative for the virus PCR, but delivered neonates to infected mother with COVID-19, they have IgM antibodies, but they are negative for the viral PCR. Clinical features mostly asymptomatic, followed by cough and fever. 30 to 40% of the kids will have rhinorrhea and sore throat. Some kids will have just gastrointestinal symptoms in terms of vomiting, diarrhea without any respiratory symptoms. Some kids will just have chilblain rash, which occurs in the feet and toes. And the last but not the least and the most important recent manifestation, which is hyperinflammation response syndrome, which is called Kawasaki syndrome, had been reported from the US and London, and it is really very scary syndrome and very important recent updates on COVID-19 in children. So I am going to explain in the next couple of slides more about this syndrome and its lines of management. Blood investigation. The lymphocytopenia is relatively rare in kids, which is different from the presentations in adult. So some kids could have normal or slightly raised lymphocytic count. CRP and BCT used to be raised. Regarding the transaminases are raised as well, and some kids also will have raised transferrin. Chest X-ray and CT is completely variable from one kid to another. It could be a normal X-ray. Some kids will present with bilateral pneumonia, which is very bad bilateral pneumonia. Other kids will have just CT finding without any clinical manifestation. CT findings could be mild, moderate, or severe bilateral ground glass infiltration with less predominant peripheral infiltration. Here is very nice and important information leaflets widely distributed through the NHS hospital to educate kids about COVID-19. In the first section here, it explains about the good hygiene habits of coughing, sneezing, the way to protect others and stay away from them. In the next section, they explain about the hand wash, hand hygiene, the good hand wash, its steps, and how it is really very important to decrease the spread of the disease. In the third part, they explain about the nasopharyngeal swab, how it is taken, because it's really very important in awake kids to have a cooperative kid in order to be able to take the swab. And the last bit here is explain about the PPE, because really it is very scary for the kids, and it gets the situation worse when you have a child with high work of breathing, high respiratory rate, and they are scared as well from the medical team. Regarding the treatment for mild to moderate cases, they need hospital admission for observation and nutritional support. They need nursing care, which is one-to-one care. They may need supplemental oxygen with a target saturation of 90 to 92%. Nutrition is very important. So if the oral feeding is not enough, they will need nasogastric tube feeding. And if they are not tolerating the feeding, they may need IV fluid, but be very cautious. So avoid under or overhydrating the kids. If the low flow nasal oxygen is not enough to maintain the target saturation, then we escalate the oxygen therapy to humid high flow oxygen therapy, but take care it is aerosol generating procedure. So make sure that the staff are protected all the time, and if you can isolate the child in negative pressure room, that's the best thing to be done. Otherwise, we need at least a closed door room, and both the child and the parent should be wearing the mask during the wave transfer from the ED to the ward. Parents will be admitted with the child in the same room, and they need to stay until the child is discharged or confirmed test has been released. This is the British protocol. The Irish protocol is different, so the parent need just to wear mask when they go in and out, but they don't have to be admitted to the hospital as well. Regarding the staff, should be minimize their time in the room as possible, and they should be protected all the time with all the necessary PPE equipment. And this process must be explained to the parent in order to avoid their frustration and to get their compliance and cooperation all the time. Regarding the aerosol generating procedures such as inserting NPAs, suctioning, high flow, humidified high flow nasal oxygen cannula, should be avoided if we can, but if it is really indicated, it has to be used with caution in terms of keep the child in negative pressure room, protect the stuff with the PPE equipment all the time, try to minimize equipment inside the room, minimize your time or stay inside the room, cleaning of the room, and also, if the negative pressure room is not available, then you're going to use a single room with double doors, and cleaning is very, very important, and I'm going to explain a little bit more in the next coming slides about the cleaning of the rooms. Awake proning for COVID pneumonia had been tried for the kids as well, and it helps to improve oxygenation, and it helps for early detection of kids who are not responding to a high escalation of the oxygen therapy and awake proning. And those patients usually they are getting high humidified, high flow nasal oxygen cannula or non-invasive NIV, non-invasive ventilation CPAP to improve their oxygenation, and they need to be hemodynamically stable. It is easy to awake prone neonates, infants, and cooperative toddlers. It could be a little bit tricky with preschool age, but in most cases it is easy to be done. If the kids are getting sick in the ward and they are deteriorating, no response to the escalation of oxygen therapy, they need to be admitted to PICU. Indication for admission: oxygen saturation less than 90% on FI2 more than 40%, oxygenation index less than 16 kilopascal, oxygen saturation index less than 12.3. If they are hypercarbic, which is rare in the COVID-19 pneumonia, and if they are having frequent apnea, if there is any signs of shock, multiple organ failure, altered level of consciousness, if the child have central hypoventilation, if there is hemodynamic instability, or if there is multi-organ failure. As you know, non-invasive ventilation or CPAP had been tried as well in COVID pneumonia, but it needs to be very, very closely monitored and timed procedure. There is no difference between high flow nasal cannula, humidified high flow nasal cannula, and non-invasive ventilation CPAP in regards as aerosol generating procedures. So both of them, they need to be ideally in negative pressure room. All the stuff must be fully PPE equipped and protected. But the consensus that usually they don't really respond to non-invasive ventilation, and it is most likely that they will need intubation. That's why it is better to have a controlled situation, and controlled kind of elective, semi-elective intubation is better rather than having a child in a very, very deteriorating, collapsing scenario. As you know, in general, in pediatric ICU, we try to avoid intubation for the kids, but here in COVID-19, the practice is different, and it is most appropriate to have the equipment ready from the start once you admitted the child, and give it a timely fashion. And if the child didn't really improve, you need to pick the right window and to have a very, very controlled situation, because you know the preparation of the PPE and the equipment is not easy. Regarding the antiviral medication, tocilizumab had been tried, which is anti-IL-6 antibody, and it had been used to combat the cytokine release syndrome. And you know, it's kind of debate and there is no strong evidence, so rely on your guidelines. You need to have a multidisciplinary team meeting between the PICU, immunology, pediatric infectious disease, microbiology specialist input should be involved as well. So if the work of breathing remained very high and the child remained distressed, the color of the child wasn't pink, and the child remained hypoxic, so it is better to have a elective controlled situation of intubation. I know that you will have a very nice presentation in this online conference from Dr. Swayfi, an excellent presentation regarding management, the airway, and intubation, but I'm going just to highlight the tips regarding the difference between the adults and peds. So here, this is very nice consensus guidelines for managing airway in COVID-19 kids. It has been endorsed by the Royal College of Anesthesia and the British Intensive Care Medicine Society as well. So here I'm going just to highlight the different practice regarding intubation in COVID-19 kids. So first of all, it is just cuffed tubes. There is no non-cuffed tube anymore. And if the child is less than 6 years old, probably you're going to use a microcuff. Intubation is only orally. There is no nasal intubation, which used to be standard in PICU, and you need to make sure that you choose the right size of the tube. It is a cuffed tube, so keep in mind the different formulas which can guide you to choose the right one, and it's a matter of experience as well. The most commonly used formula is age divided by 4 plus 3.5 for cuffed tube. Regarding the intubation instrument, it is just only video laryngoscopy, and it can guide you to have the right length of the tube as I left it. You know, it is very, very important in peds to avoid unilateral ventilation, lung collapse, and hypoxia. And also regarding using the video laryngoscopy style, it is highly recommended to be used. And the most important tip is just to have the tip of the tube and the distal part is bended and curved the same way of the blade of the different video laryngoscopy instrument you're going to use, either if it is McGrath, C-Max, or kaleidoscope. So make sure that the curve of the blade and the distal part of the tube, including the tip, is shaped and curved the same way of the blade to maximize first go success. And then regarding the number of the staff in the room, you need to limit the number, not like before. So one will do intubation, one will assist with the intubation, and having surgical airway kits ready if needed, and third one will give drugs and watch the monitor at the same time. Of course, you may need help, so the runner will be outside the room because the intubation will be happening in a negative pressure isolation room, and the runner should have a clear, good communication with the team inside the room and with the helper or second team for intubation in case if they are needed. The team is needed. And regarding the staff need to be fully protected and equipped, so PPE equipment, and consider double gloving, so the one glove will be taken out after intubation, and make sure also you have the blade covered or cleaned or disposed. The best way to have a disposable probe rather than having a re-cleaning blade. And make sure that you having you are wearing defog goggles and eyewear as well if possible, and try to minimize touching anything in the room. Here is very nice published paper in Anesthesia Journal. It came from Italy regarding their experience in the COVID-19 outbreak. So I want to show you about the mask to see here. The different masks has different protection rates. So FFP1 will give you 80% protection, so 80% filter capacity, and FFP2 is even better, give you 94, N95 will give you 95%, so 95 is 95 is the same. FFP3 will give you 99%, so I think most of the hospital have the highest one is FFP3, but if you are lucky and have N100, use it. It is the best protection mask. Before intubation, you need to make sure that you have already the weight of the child, which is really very, very crucial for the dosing of drugs. And if you don't have the actual weight, probably the estimated weight could be used. You need to get your drug ready, prepared, and you need to make sure that you have the right size of the equipment is being used, because you know it is different in peds from adults, so you have different sizes of tubes, different sizes of plates, different sizes of suction catheter. So you need to make sure that you have the right size according to the age and the weight of the child, and this all to help you to maximize the chances of the first time airway management and success. Regarding how to ventilate a child before and after intubation, so you can use the iris T-piece. It is not an open circuit. You can have the filter directly attached to the mask, and then this is the only way to protect yourself. And make sure you have a good seal between the masks. So you need also again to choose the right size of the mask. And this circuit should have the HMV-ME filter attached all the time, and it could be used for all kids with weight less than. Regarding the back mask ventilation, this is the same consensus guideline I showed you before. And here regarding the how to back mask, always two hands time now in COVID-19 pandemic, so it is V and E rather than C and E is not used anymore. Here is very important and very nice emergency tracheal intubation checklist. I believe it should be printed, laminated, and attached to every intubation trolley in every pediatric ward, PICU, or theater as well. So here, the beauty about this chart, it has three important sections. What should be done before you enter the room, outside the room, and then inside the room, and then after you intubate the kid. So outside the room, you need to make sure that you have your PPE ready to go, and you need to make sure that you are having the right way of using the PPE. So it is just two persons initially, or two staff. One will get the gear in, and the other one will check the stuff to make sure that it is already in the right order, in the right sequence, and it is already the stuff is well protected. So it is really very important. As you know, it is a common infection between the health care workers, so we need to protect ourselves, otherwise we can't really help the patients. And so this is the first part of it, is PPE, and then you need to have a discussion between the teams. So the intubation team will be three, as we said. One will tube the child, so who will be the intubator? Ideally should be the most expert, the same as adults. I'm sure this will be covered very well in the Dr. Swafi presentation. And then who will do the cricoid pressure? This will be the airway assistant, and drugs doses should be ready to go. And then the runner, who will be the runner, and who is the secondary intubation team to be called in case if there is any help needed. And then also outside the room, you need to check your equipment you're going to use. So make sure all intubation kit ready. So it is just a tick boxes to make sure you're not missing anything, because it's really very stressful time, very critical time. It's not easy to go to tube a child who's going to deteriorate very quickly, and then you're missing one of the necessary bits outside, or not in the unit even. The weight of the child is very important, because it is all dose dependent medication. And then regarding the drugs you're going to tube, and in the next couple of slides I'm going to explain more about the choices for drugs to be used. And also what's your backup plan in case of difficult intubation. So airway management, it is a planned procedure. It is not just a simple straightforward intubation through video laryngoscopy. You need to have a plan A, plan B, plan C, plan D. That's very important. And then inside the room, everyone knows his role, and clear instruction, clear communication, that will make the success of the team easily. And then after you intubating the child, it's very important. So after intubation, immediately inflate the cuff and connect the HME filter, and then start ventilation. So there is so that's very important. Try to minimize connection, and try to minimize any aerosol generating procedure in the room. Try to minimize the equipment in the room. Try to minimize touching anything, decrease the number of the stuff. And then you need to have the inline suction directly connected in with the ventilator. I'm going to highlight another different points regarding intubation in COVID-19. So after intubation of the kid, you need to inflate the cuff to an equal cuff pressure of 20 centimeter of water, and this could be increased later on if there is any leak. And also make sure you have inline suction which is directly connected, and try not to break the circuit all the time. And if you have to do disconnection, make it distal to the filter. Make sure you are using clamping of the tube all the time, and mechanical ventilation is off before you clamp the tube and before you disconnect. Continuous waveform capnography is a gold standard tool for monitoring. Clearance of any aerosol generating is dependent on the ventilation of the room. Usually in the hospital rooms, it is commonly 12 to 15 air cycles every hour. That means probably after 20 minutes of any aerosol generating procedure, less than 1% of the amount of the virus will be in the room. So that's a perfect timer. After 20 minutes you switch on the timer after any intubation, extubation, nebulization, disconnection, and then after that you start to clean the room. Try to avoid any reusable equipment as much as you can, and try to protect the ventilator with a high efficiency filter. And this should be used in theater and PICU in every intubation room. Here is a very nice published paper from Singapore. Really, they have a very good preparation during the COVID-19 pandemic, and they have a lower number of cases and lower mortality than other countries. What they are used is kind of plastic covers, plastic sheets, as you can see here, to cover all the monitors in the operating theater, in the intensive care unit, in any intubation room, and also the back of the ventilator and theater. And actually we use the same, and also we use to cover the monitor, and also we use the plastic sheet, same plastic sheet for intubation and extubation of the kids. Regarding intubation drugs, so as you know, the first line for intubation will be ketamine, especially in PICU patient. Second line, you can use adjuvant with fentanyl. Neuromuscular blocking, now it is a standard practice in all COVID, is neuromuscular blocking agents should be used, rapid sequence induction before. In kids, we don't use it in all cases, as pediatrician knows. So rocronium is the first line, then vicronium, and if you don't have both, you can proceed with pancronium, metacronium. Succinylcholine still could be used, and some people would like to have atropine ready to go in case if there is any bradycardia after using of succinylcholine, but it is not a common standard practice. And then if you're going to use a neuromuscular infusion, so still rocronium is the gold standard first line, and if you don't have rocronium, you can proceed with vicronium, and if you don't have vicronium, then you can use atracronium or pancronium. Maintenance of sedation in PICU, usually it is midaz first line. If you don't have midaz, then you can use clonidine, and other alternatives like dexmedetomidine is very valuable and had been used. Propofol is rarely used in kids. You can use different benzodiazepines as diazepam, lorazepam, chlorohydrate is very common to use. And regarding the maintenance of analgesia, morphine is the most common first line of analgesia. If you don't have morphine, you can go with fentanyl, and then the other adjuvants or non-opioid like clonidine, paracetamol. Very cautious with non-steroidal anti-inflammatory. Vasopressors infusions commonly to be adrenaline or adrenaline. If there is pulmonary hypertension, you can use milrinone. And the next line will be dopamine. The third line is vasopressin. If you are going to transfer the kid for the CT is not a mandatory test. It should be done when it is really indicated. Probably it won't really change the management, but if there is any transfer for radiology or for operation room, so you need to have sedation on board. So propofol, TCI could be used during just time to propofol. We try to avoid using propofol infusion in general, and for kids, and especially for a long time. And midazolam. If you don't have both, the alternative will be midazolam, lorazepam, diazepam. Dexmedetomidine as well can be used, lorazepam or diazepam. And regarding the vasopressor boluses, usually we don't really bolus the kids, but in case if you need, metronidazole is the first line, and if you don't have it, the second line will be phenylephrine or ephedrine. The last updates about COVID-19 in kids is really scaring news. It had been in the media everywhere, even up to yesterday. So As you can see, it is a rare syndrome, and it was initially reported from UK, and really people get scared about it, and so it is really frustrating and scary news, and it is in the media now almost every day. And the European Centre for Disease Control issued a great concern and caution regarding the syndrome. So this is the first case scenario to describe clusters of children presented with hyperinflammatory shock during COVID-19 pandemic. 8 children, their age was 4 to 14 years of old. They are based in London. That was in mid-April 2020. 8 of the children having a good weight, more than 75 centiles. That means they have no other comorbidities. 6 of them were Afro-Caribbean, and 2 were Asian. There is no Caucasian children in this cohort. 5 were boys. 4 children were exposed to family members who had a positive COVID-19 test. The clinical presentation was like Kawasaki disease, so they had a fever, rash, conjunctivitis, peripheral edema, extremity pain. 10 of these children were SARS-CoV-2 antibody positive. Clusters had been noted in the US as well, particularly in New York, and also in some centers of UK, Spain, and Italy. They have gastrointestinal symptoms as well. All children developed warm vasoplegic shock and required inotropic support. 7 children required mechanical ventilation. Chest X-ray had showed small peripheral pericardial and ascitic effusion, and there was diffuse inflammatory process were also observed. The echo showed bright coronary arteries. 1 child has a giant coronary aneurysm, and 1 child died from large cerebrovascular infarct, and myocardial enzymes were significantly raised. Adenovirus and enterovirus were isolated in 1 child. 4 children had known exposure to SARS-CoV-2 family members, and 2 of them had tested positive, and 1 of them unfortunately was postmortem sample. All children received IVIG and broad-spectrum antibiotics like ceftriaxone and clindamycin. 6 children have been given aspirin. The clinical presentation may represent a new phenomenon associated with SARS-CoV-2 infection in children who had remarkable similarities to Kawasaki syndrome. That was reported in Evelina, London Children's Hospital, and they manage more than 20 similar cases of children. Here is a very nice guidelines from the British Pediatric Intensive Care Society to guide the management of that condition, which looks like Kawasaki syndrome. So just I'm going to run through the guidelines very quickly to highlight the most important lines of management. So treatment of those kids, it is a multidisciplinary team approach. So it is encouraged to have treatment decisions between different teams, mainly cardiology, infectious disease team, and rheumatology or immunology, just depending on each hospital policy. Transport team conferences, so you need to have a call facilities that may help to triage the decision when the kids are firstly presented. And you need to take a very good caution, because moving those kids, they are unstable and they can collapse during movement, and they have cardiovascular instability as well. Cardiac ECG and echo is really very important and recommended to check the cardiac examination and the cardiac dysfunction, and especially there are reports, as I told you, about coronary artery abnormalities. Some kids will have abdominal symptoms, and it will be severe enough to trigger the need for radiology, just to exclude any surgical condition. And they usually manifested with vasodilatory shock, so which is relatively refractory to fluid boluses. RRT it is not really used for those kids, but it is a treatment option if it is needed. The cardiac output is really very important. Cardiac function may evolve very quickly in those kids. Cardiac output is very sensitive to inotropes. If there is only peripheral line, so probably you're going to use dopamine or adrenaline. Noradrenaline, vasopressin need to have a central line. And if there is any evidence of cardiac dysfunction, which probably is more likely to be found in those kids, you need to have daily assessment and very close assessment of the cardiac function. And also you can start adrenaline, milrinone, levosimendan to support the heart. Extracorporeal life support could be needed. It's only here in this report 3 kids who have required ECMO. So since the progression of the cardiac function can be rapidly and unpredictably, it is preferably to have a transfer of those kids with to ECMO center or ECLS center. And if they need ECMO, probably it will be a VA, veno-arterial ECMO. And you need to have a caution because those patients is most of them are prothrombotic, and so take care regarding the anticoagulation. Regarding the mechanical ventilation, it was required in around 60% of the patient, and it is mainly to support the respiratory or the cardiac function, or just to help to have the line insertion. Non-invasive ventilation, high flow nasal cannula had been used successfully in some kids without any need of invasive ventilation as well. Regarding the mechanical ventilation settings, it depends on the lung compliance, as you know, the same way in the adults. Nitric oxide had been used successfully to improve the oxygenation. Antibiotics and infection control, as you know, the SARS PCR testing inconsistent serology commonly to be positive if it is done, and there is no evidence of viral of co-bacterial infection. So the local policy of using antibiotics is different from one hospital to another, so stick to your local hospital policy. As you know, there is a risk of venous thrombosis, so approach to anticoagulation here, the practice I have seen, it is just a prophylactic dose of low molecular weight heparin, but here in this report they have used a high dose of aspirin had been used as well. So aspirin high dose can be used, and it needs, you know, as you know, it is multidisciplinary team management. You need to have a conversation with hematology team and approach to immunomodulation as well. So IVIG had been used, steroids at all debatable, there is no strong evidence, and it need to have a discussion with the local team. The role of antiviral is also questionable, and they in this paper they have used different antivirals like remdesivir and ritonavir, so it's according to your hospital policy. As you know, in general, tracheostomy in beats is very rare, and we try to avoid it, and we try to allow more chances for extubation in kids, but here it is a different situation. So if you have a situation and you struggle with the extubation of the kid, and you're going for tracheostomy, it is the same practice. We're trying to avoid it, but just in case if it is a must, as you know, tracheostomy in COVID-19. Here is a very nice paper here emphasizing the use of the PPE. So we need to make sure that you are covered using the cap, the shoe cover, the mask, goggles, face shield, gown, and regarding the theater should be ready. The most expert of the team should be doing the tracheostomy. Limit the number of the staff during the procedures. Appropriate. And regarding the trachea itself, make sure you're having muscle relaxant on board all the time, checking using the saturation, the capnography of form. Here it is mentioned very important tip, just to push the tube cuff caudally to avoid any air leak, and immediately inflate the cuff before starting any ventilation. And of course, you know, there is kind of debate, so people are saying it's better to avoid percutaneous tracheostomy, and surgical tracheostomy without any bronchoscope is less result generating procedure, and theoretically is more protective to the stuff. So after intubation, you need to make sure that inline suction is already connected, regular cuff pressure check, and planned cannula change, and the wound closure when possible. Regarding the outcome of Kawasaki syndrome patient, usually the length of stay in PICU is generally short, around 3 to 4 days, thanks to God, and the great majority of the patient will survive. Just I'm going also to quickly highlight the difference in the cardiac arrest management in COVID-19. Your PLS for pediatric life support, you need to make sure that you have your PPE first done in the right way. So you have your gear is on, and you need to limit the number of the personnel in the room. And here in kids is different from adults, so we are going to use a backmask device, but we need to make sure that there is a filter and there is a tight seal. So we are actually bagging the kids because, even in COVID-19, because hypoxic cardiac arrest is very common cause of cardiac. And when you are doing the pediatric life support, it is very important, as I said, that it's a ventilation, it's a gentle ventilation, there is a good seal, it is V and E, not C and E like before, and you need to make sure that everything is ready for intubation straight away. So intubation is a priority in the situation. So you actually pause the chest compression for intubation. You need to have the most expert intubating member of the team to go ahead, and don't delay intubation. And of course, you need to have the filter directly connected to the tube and start after inflation of the cuff. This cuff tube start to have backmask ventilation. And if there is any difficulty, you can still use supraglottic airway device, but again with the filter. So that's the second change here. And you need to make sure that the ventilator is connected after that. And keep in mind all the time, minimize disconnection of circuit, and use inline suction. And as you know that, as I said, the most expert to do intubation, and try to use video laryngoscopy as a standard intubation as well, even in this situation. And hopefully it won't take much time to get the tube in if you have the expert having the tube in the right shape and right curve of the laryngoscope, and it is cuffed tubed. Here is the references I used to prepare this presentation. Thanks for your time, and thanks for watching.